Welcome to this presentation, which will be around 10 to 15 minutes, on some research that was done by the NSPCC and one of the social service research departments, and they came up with a series of questions and issues that were raised called the 10 pitfalls in the practice of children's safeguarding. And what I've done is to take 6 out of the 10 recommendations and translated them into questions and issues that we as healthcare professionals should be mindful of when we're doing child safeguarding. This is for the Acute and Emergency Paediatrics module, MDM 158 of the Master's Programme at Brighton and Sussex Medical School. And we're going to use some of these recommendations and kind of questions and queries that this brings up in the classroom practice on day 4 of the module, when we do formulation and opinion writing on some cases. This is the actual piece of research done by Professor Sue White and Dr. Karen Broadhurst, who are researchers in social care based in London, and the piece of work is called 10 Pitfalls and How to Avoid Them, published in September 2010. So the first one regards the fact that as healthcare professionals, but also as social care professionals, an initial hypothesis is often formulated, and this will often necessarily be on incomplete information, but then the assessment is accepted perhaps too quickly, and this could be viewed as a form of anchoring bias, where initial information is weighted too much, an element of framing bias, so that the nature and the way the information has initially been obtained and the incompleteness of it may actually make us view the information and data with a particular slant, depending on sometimes how the information has been viewed, kind of obtained, and how it's presented to us in our own minds. And furthermore, that it's been noted that social care practitioners, and therefore I think healthcare practitioners too, can often become committed to this initial hypothesis and then kind of stop looking for further information that might either disconfirm or refute the hypothesis, and this is a form of confirmation bias or leading to premature closure. So confirmation is represented in the bottom right-hand cartoon, where you've already kind of made your mind up and you're looking for information to help substantiate that you're right, as opposed to sometimes more correctly addressing this by looking for information that might prove you wrong instead. The second take-home point from this piece of research was that at first inquiry, information may not be adequately recorded and the facts not checked. And I think I've interpreted this that this may happen because none of us want to come to work thinking that we're going to be seeing children who have been abused. And so there's an element of initial disbelief or denial that this may be the case, and therefore we need to overcome. And that, particularly when we're busy and we're not really wanting to look for it, that we may therefore not record the facts accurately or adequately, nor inquire the facts with a thorough history. And sometimes a reassuring lie is more palatable than an inconvenient truth. The third point addressed the fact that the most visible or pressing problems draw our attention and focus, and that the less obvious details and the wider aspects are sometimes insufficiently explored. And to combat this, because this is, we must accept part of being human, is to use pro formas or checklists, and we'll certainly be using a pro forma when we do the classroom work on day 4 of the module. And maybe the other aspect of the reason that we tend to focus on the most visible or pressing problems is our brains can sometimes have a tendency to oversimplify, and this may be because we have difficulty with grasping and dealing with different shades of grey and uncertainty, and our desire for a resolution may cause us to overlook details. I found this particular point really quite interesting, because you could ask the question, how come, if you're dealing with safeguarding as a social worker, or you're as a healthcare professional dealing with children, how come then insufficient attention can be paid to what children themselves say, how they may look and how they behave, and looking particularly for evidence of how they look and how they behave and how they move can be overlooked. Some of this may be because we may not feel confident or feel that we have the skills in seeing and speaking to children and young people, particularly those with different needs and with different abilities. So where language, maybe deafness, disability are clear examples of how it can become a challenge. So then it's up to us, I think, as individuals to gain those skills and confidence and make sure that we have them. Another aspect is to really think about, are we going to see the children on their own, so they're not influenced by their carers or parents. And in particular, there are times when we have to ask the question, does the child appear to be coached? And also think about what is the evidence, either to support or to refute the account given by the child and young persons. And maybe we need to also overcome the tendency that we're going to believe adults over children, and that's a maybe deeply ingrained kind of societal or cultural belief. Now we have an interesting view on how we prioritise who is vulnerable, and it's not unusual that particularly the initial decisions are kind of looked specifically with younger children being prioritised over older children in whom maybe the risk is thought to be lower. And there's recent research suggesting that agencies don't always respond appropriately, for example, to neglect in adolescence. And this is reflected in that older children are less likely to become the subject of child protection plans, even though the neglect issues may be very significant. We know that, young people who are, inverted commas, hard to help, close inverted commas, are particularly vulnerable. And services can be inappropriately scaled down in the face of a resistant young person, particularly where there's a long history of involvement with services. We as people and agencies can become desensitized and therefore end up withdrawing. children presenting to agencies can be experienced as more demanding than younger children because they want clear assurances of confidentiality. They may require control over the help-seeking process. And so the emphasis then is very much on us as professionals really thinking about, have we considered all the risk factors, some of the risk factors around, for example, child sexual exploitation, about going missing, self-harm, missing school, what other mental health issues are going on, etc. And then, kind of lastly, there often can be misunderstanding or lack of understanding because we think we've said or shared some information and made the assumption that this has been understood, and that we don't necessarily always check that it's been understood. So discussing these matters where we share our mental models and our thinking, we need to demonstrate methods of checking that we've understood. So that's then also modelling that good practice. And particularly if we are leaders in our workplace, then looking at the culture, and is it effective, is it conducive to effective and accurate communication? And in order to do this, relationships need to be actively fostered. So that's a summary of 6 of the 10 pitfalls as I think they apply to healthcare professionals, and I've added my interpretation of why we may fall into these pits and some of the biases that might be involved. It'd be interesting for me to hear what your views are in the classroom of the pitfalls if we have time, and particularly if there are additional biases that you've come across or have thought about that might be impacting and influencing. Thank you very much for your time, and bye for now.